conducted our research on type 2 diabetes in Guadalajara, Mexico, because in recent years there has been an increase in the number of type 2 diabetes cases seen in this city, as well as within Mexico as a whole. Before we delve into the content of our presentation, we want to spend some time talking about a woman named Mel. And Mel is a 45-year-old woman who was born in Sinaloa, Mexico, and she immigrated to the US when she was 3 years old. She has 5 children, and at age 18 she was also diagnosed with type 2 diabetes. So we're telling you her story because we think that it might give you some insight into at least what one Mexican American experiences as a type 2 diabetic. And so Mel said, "When I was pregnant with twins, only one of them survived." So it's interesting to see that this affects me at such a deep level. Healing from puncturing my finger takes so freaking long, I look like a drug addict. And so we see here in this quote from her that type 2 diabetes is not just something that she goes to the clinic once a month to take care of, it's something that has had a profound impact on her in her day-to-day life. So just to give you some insight into type 2 diabetes in a global context, it is the most common chronic metabolic disease in the world. It also primarily affects older people. In terms of prevalence, among those who are at least 18 years or older, it has increased dramatically from 1980 till now. In 1980, the prevalence was 108 million globally, and now it's 422 million, so definitely a significant increase. In terms of prevalence in percentages, it has increased from 4.7% in 1980 to 8.5% in 2014. And in 2012, 1.5 million deaths were attributable to type 2 diabetes.
Now that we have a very clear understanding of how diabetes affects people worldwide, it's important to understand how diabetes affects people in Mexico as well, as there are specific reasons as to why diabetes is so prevalent. In 2001, there were 1.4 cases for every 100,000 people, and in 2006, there were 14.4% of people with diabetes, 7% of which went undiagnosed. Of these people who did have diabetes, only 5.3% of patients were able to manage their diabetes in a correct way, 38% of which had deficient management, and 56% had very deficient management. Overall, it causes 14% of deaths in women and 9% of deaths in men. $1.12 billion went for direct and indirect costs, and $941 million were directed for direct costs. Looking at diabetes on these prevalence graphs, you can see the difference between women and men. The different lines represent different years. The lowest one was 1960, and it went up to 2010. You can see how diabetes has become so prevalent as the age goes on between the 60s towards the 80s. So if you also look at the incidence graph, you can see between 1960 to 2010 how it has just become a much more prevalent problem in the recent years. Overall, Mexico population is very large. It contributes to 12.1 million people. There are 3 ethnic groups, 62% of which are mestizo, 28% indigenous, and 10% European. As for the language, about 93% of people speak Spanish, and about 7% speak indigenous tongues such as Mayan or Nahuatl. The religion is 83% Catholic. As we look at Mexico's population pyramid, we can see that we have a fertility rate of 2.27 children per woman and an obesity rate of 27.6%. The population growth rate is 1.8%. We have a population that is bigger between the ages of 0 to 14, which is 27.59%, and for 65 and older, it is 6.77%. This can cause a problem as the younger generation grows older, they will have a likelihood of developing diabetes, and so the healthcare expenditures will be much larger. In order to understand how Mexico works, it's important to look at its economy. So Mexico's GDP is $18,500. The problem is that 40% of Mexico's income is owned by the top 10% of its population. This causes an unemployment rate of 9.2%, and 52.3% of these families live in poverty. As for education, the literacy rate is 95.1%, and the school life expectancy is 13 years. As a whole, there's a life expectancy of 75.65 years in Mexico, and the mortality rate is 5 deaths per 1,000 people. 6.2% of the GDP goes to healthcare. There are only 2 physicians per 1,000 people. The healthcare system has 88.5% universal coverage. It includes the private sector, a public sector, and right now the most popular program is Seguro Popular. It involves voluntary enrollment, so not everybody is covered by this. It is also not dependent on your health status, and the cost is determined based on your socioeconomic status. This being said, it ranges from $152 to $834 per year, and have to be in the lowest 4 decimals of income to not have to pay anything.
Guadalajara, capital of Jalisco, Mexico, which is the second largest city in Mexico in terms of population. Currently right now is approximately 5 million people. It's a rapid growth since World War II. It's due to the migration from the rural areas. In 1940, the population is 400,000. The industry and the agriculture are very intriguing because the Mexico Silicon Valley had produced 60% of the computers, and they are the largest producer in corn and sugar. Residents are primarily Spanish-speaking mestizos, which identify both as white and indigenous. The indigenous background is linked to use of the traditional medicines. The nopal juice absorbs the sugar in the pancreas. The range of the social economic classes, the middle class and the poor neighborhoods. The census in 2000 was 84% Catholic. The emotions are very important here. Folk believe what causes diabetes is susto, coraje, and nervios. Susto is an unexpected fright. Another emotion, coraje, which anger and rage are believed to cause diabetes as well. Nervios, because of the nerves in your body. The idea of machismo, which is male authority. Women are positioned to be the caregivers. One of the qualitative studies found that husbands that do not support their wives in adopting such health behaviors necessary to control diabetes. A good friend of mine had something very unique to say. My husband is a wounded warrior. 2 months ago, he was permanently disabled. I take care of him. And if I don't take care of myself, no one will, she said. The traditional foods, many of these foods diabetics should avoid for the simple fact that a lot of them are greasy, a lot of them have starch, a lot of them have a high cholesterol, a lot of them have a lot of carbohydrates. Those foods are pork, beef, coffee with sugar, bread, tortillas, taquitos, birria, goat stew, menudo, stew with cow stomach, pozole, which is corn, and chili stew. A lot of these foods have a lot of salt, which is bad for you. A lot of carbohydrates, a lot of grease in a lot of these foods.
Okay, so now we're going to move into a discussion about what factors public health professionals might want to consider when conducting an intervention in Guadalajara. So looking at our PEN3 model, we know that there are both perceptions, there are enablers, and there are nurturers, which are people in the community. There are also positive, existential, and negative components. So we're going to talk about perceptions first off. There are a number of positive perceptions. The first is there's often lack of stigma around type 2 diabetes, and we'll talk about why that is. Many patients have learned to develop coping mechanisms, so they have learned to live a full and happy life even though they have this disease. In terms of existential perceptions, diabetes is often attributed to strong emotions like susto, coraje, and nervios. Type 2 diabetes is often attributed as well to urbanization. Also, we talked about this a little bit, but males are positioned as authority figures in this culture. And for that reason, females are often burdened with caregiving. They also have an interesting relationship with their healthcare providers. And so although machismo cannot necessarily be changed because it's so embedded in the culture, it's something that definitely public health professionals need to be aware of. In terms of negative perceptions, there is acceptability of drinking, which is a risk factor for diabetes if it's done in excess. As well, some diabetics are unaware of their condition, and also some diabetics experience depression or guilt or shame upon receiving their diagnosis, which is obviously not conducive to them learning how to live with their disease. So in terms of positive perceptions, I said that there's a lack of stigma. And the reason for that is that there's a high prevalence of the disease, and it's also known that it has a hereditary basis. And so because of that, it's so widespread, people are accepting of it, and also people don't really shame each other for having it because genes are obviously outside of your control. These are also some quotes that show how people have learned to adapt with the disease, as I said on the last slide. These come from a qualitative study that we read, and the first quote says, "I accept my disease and take care of myself." It is my companion, and that helps me to overcome diabetes because I have this disease and have to walk with it. Another person said, now and then I eat pozole because I like birria a lot or menudo. I buy only little so that I eat it and have none left over in the pot. So both of these people talk about how they've learned to live with the diabetes. In terms of existential perceptions, there are oftentimes psychosocial causes of the disease that people believe in. So they believe that it's attributed to emotions like susto, which is fright, coraje, which is anger, and nervios, which is a combination of anxiety and nerves. It's also attributed to the stress of urbanization. So as we talked about earlier, Guadalajara had a relatively small population during World War II, but it had significant population growth following that period. And so people remember how calm and peaceful Guadalajara was, and so they attribute type 2 diabetes to the rise in traffic and crime and crowding that is now in Guadalajara. So we say that these perceptions are existential, even though they are not necessarily consistent with the biomedical causes of type 2 diabetes. We still think that people can learn how to adapt to living with type 2 diabetes without necessarily having a correct understanding of where the disease comes from. Also, going along with that, it's really helpful for people to be able to ground their disease in a cultural framework and therefore make meaning out of it. So in terms of negative perceptions, substance use is a risk factor for diabetes. Nationally, 19.7% of men and 5.3% of women have engaged in heavy episodic drinking within the past month, and that's defined as drinking at least 60 grams of pure alcohol on at least one occasion. A national survey is conducted, 10% of diabetics were unaware of their condition. So this slide shows the PEN 3 model in terms of enablers. And so what you can see on here is a number of different things. There is a preventative health program going on that Instituto Mexicano del Seguro Social has implemented. There are also national health guards, patient support groups, media campaigns, and indigenous treatments like Nopal juice. Nopal juice is an indigenous treatment that helps people regulate their blood glucose levels. In terms of existential enablers, many cultural foods are simply not part of the diabetic diet. In terms of negative enablers, there's no national surveillance system. There's also no defined method for conducting screening. There's limited use of insulin. There's inadequate diabetes education for patients and community members. And there's also an equal access to healthcare services. So this quote is another quote from Mel, and it just says, no, her family's not educated about diabetes. A lot of the family still eats fast food or other things they shouldn't eat. A lot of them are overweight, and sometimes it's by choice. They would rather live a good rather than a healthy life. So in terms of positive enablers, Preventimus is a preventative health program that was instituted in Mexico in 2001, and its two main objectives were to, one, reduce duplications in preventative care programs by targeting preventative care approaches to specific age groups. Also, there is an emphasis now on coverage instead of productivity, so making sure that people who really need preventative care services are getting those. There's also been an increase in type 2 diabetes screening as a result of Preventimus. So for men between 2003 and 2006, it increased to 57.8% from 38.6%. For women, it increased to 66.5% from 45.3%. And for older adults, it increased to 65.2% from 34.8%. So this has been very effective. If you look at what the Instituto Mexico del Seguro Social is also doing, they have these national health cards, which include information about what preventative services patients have received and when they need to receive their next preventative health care services. And these are something that patients carry around with them. There's also patient support groups, a huge asset, because now patients are not just passively receiving information from their healthcare providers, they are also taking an active role in their diagnosis by sharing their insights with other community members and by supporting one another. The Ministry of Health has also created a media campaign called 5 Steps for Your Health, which focuses on what individuals can do to decrease type 2 diabetes and to prevent themselves from getting the disease. It's been broadcasted in 440 television channels and 750 radio stations, and it is estimated to have reached 70 million people. So in terms of negative enablers, there's lack of coordination. Each Mexican healthcare system collects its own information about diabetes-related outcomes, but never consolidates it into one database. Insulin is also only prescribed to 6.8% of the population when it should be prescribed to 20%, and this is within the Guadalajara specifically. There's also an inadequate education, so diabetic patients' beliefs about causes, symptoms, and treatments are resembling those of their community members and not of those of doctors in at least one study that was conducted. There's also an equal access to healthcare services, so Seguro Popular does not cover treatment for major diabetes complications, and so people either have to go without that or pay out of pocket, which obviously has implications for increased morbidity and mortality.
PEN 3 model. The nurturers As far as the positive, Kinship Works family participate in caregiving. Each and every person within the Kinship Network and families that participate in caregiving should continue to do this. In the existential machismo, the wives already support the husbands in efforts of helping them as a caregiver. The husbands don't participate in doing the necessary things to help the wives out. In this quote here, the husband does not want to pay attention and refuse to eat less salt and more vegetables and says the diet is disgusting. This quote here is stating that the husband isn't given any of encouragement to taking care of the wife as well as he is being taken care of from her. The negative part is the physician. They're not educated enough to be able to take care of those that come in that need the help. They need the appropriate training and they're not getting it right now. As this diagram here shows, that family physicians, clinical aptitude, there are no high clinical aptitude frequencies and percentage. They're very, very low, and they need to be able to be dealt with.
After conducting our research on type 2 diabetes in Mexico, we have come to the conclusion that there are a few cultural oversights that need to be surpassed in order to provide the right care for type 2 diabetes. The first of which we realize is inadequate training among healthcare professionals. If they are not equipped with the right information to help patients deal with diabetes, then it can be very hard for the patients themselves to understand the steps that are necessary in order for them to get better. As for biomedical interventions, we have realized that a lot of these interventions target the patients themselves and can often exclude community members, which is important as we discussed because of kinship and because if these people who are just community members do not necessarily have type 2 diabetes now, does not mean that they cannot use this knowledge further on to either care for a family member or to care for someone in the community that needs their help or even themselves. As for cultural understanding of diabetes, it can be very difficult to do this because of the distance between what a patient hears on their day-to-day basis versus what a doctor might tell them, such as medical jargon that may not go understood between the two of them. It can be very easy to sustain that information in your head without really understanding what it implies and what it really means. And this becomes important when we talk about management versus treatment, because talking about treatment is very different from talking about coping mechanisms for them, such as eating the right foods or eating smaller portions or making sure that you get enough exercises done. And so it's important to take these smaller steps rather than just giving them a whole picture of what needs to be done, such as taking certain pills or taking medication. As for gender dynamics that are not being taken into account, we discovered that caregiving is very important among mothers, and they are always very careful to make sure that their families have the right supplies that they need. And oftentimes this can be reflected in the provider-patient relationships in the sense that women are more often the ones that seek out help from medical professionals rather than men. This can be due to machismo, but in a way machismo can also reflect why it is so difficult for women to get the help from health professionals, as oftentimes the health professionals are men themselves. And so it's a situation where there might not be the communication necessary because of these gender dynamics. So it's important to see how these gender dynamics work out in Mexico's culture because they have an effect on how they get help for type 2 diabetes.
Okay, so now we're going to talk a little bit about what we think public health professionals should consider doing when they create an intervention for type 2 diabetes in Guadalajara. We first think that healthcare providers really need better diabetes education. Instead of expecting them just to assimilate that information during their 3 years of training, there should be a specific class offered to them about caring for type 2 diabetics. We also think that perhaps they need to have more cultural competency. So we suggest that perhaps community members or patients with type 2 diabetes should somehow be in a type of relationship with their doctors, some type of setting where they can actually educate their healthcare providers about cultural competency and actually give them the position of teaching their doctors instead of always their doctors teaching them about what type 2 diabetes is. We also think the next step of this is making sure that community members also have type 2 diabetes education, because right now community members are very much left out of any education efforts. And as we talked about, community members are a key part of caregiving in Mexico and specifically in Guadalajara because of kinship networks. What should perhaps be happening is that clinics should be educating patients and community members about type 2 diabetes because patients also need more education anyways. And then those patients and community members should then be going out and spreading that information to other community members, much as what we see happening within the School of Husbands that we learned about earlier this semester. Also, we think that diabetes screening should be incorporated into primary care immediately starting at age 10 by using an A1C test at every checkup. And we talked about what that is in our handout, but that is a standard of care for diabetes. Now, we think the last part of it should be that there needs to be a national database for type 2 diabetes information. This would be specifically helpful in Guadalajara if there is one place where everyone is depositing their information. Healthcare professionals can decide who needs what types of diabetes care. This is specifically relevant to insulin because, as we talked about, not as many patients are being prescribed insulin as they should be. That is all that we have to say about type 2 diabetes. Thank you for listening. Do you have any questions? We're more than happy to answer those questions for you.